is Riley McClellan. Today I'm going to be talking to you about blood health prediction using NHANES data. So, why is it not going? There it is. A little bit about myself to start though. I went to ASU where I studied kinesiology and taught anatomy labs. I then worked in airlines for 3 years, and I'm an avid gardener, climber, and hiker, as well as a health nerd, and a very excited data scientist. So blood health has a lot of different things to it, but we're going to look at cholesterol specifically. Total cholesterol over HDL is going to be a ratio that's often used to tell how much risk patients have for heart disease. And if it's high for too long, then patients can develop hypertension and heart disease. So those two things are way more expensive for insurance companies to treat than cholesterol itself. And so I wanted to make a tool for doctors so that they could predict better which patients are going to need these tests. So what is NHANES? Well, NHANES is the National Health and Nutrition Examination Survey. Sponsored by the government, it goes around collecting detailed, comprehensive medical evaluations, and it saves that information for research. Our sample population is aged 20 to 80 and is pretty evenly spread between male and female. We have a cholesterol ratio on average between 3 and 4, which is a healthy number. That's what we would like to see for everybody. But we do have some people that fall above this 5 range, which is where you have an increased risk for heart disease. NHANES has quite a bit of factors. It's got close to 1,000 potential factors that could have any type of relationship with different markers and diseases. It's not really outlined for you because health is very complex. So you have to use a lot of statistics and research to identify which features are going to be useful to the model. So as an example, on the right here, we have like caffeine intake, and that is related to heart disease. And we could potentially look at markers, but it doesn't really have a connection to cholesterol, it turns out, so we can't include that in the model. Another example is going to be dietary sodium, which is definitely going to have an impact on heart disease. And it's related to this other factor over here, dietary fat, which does have an effect on cholesterol, but for whatever reason, the data just doesn't support a connection here. So we can't include that in the model either. Then we have other factors like DEXA scans. Those DEXA scans are super indicative of cholesterol levels. However, they're way too expensive. It's a lot less expensive to just get a cholesterol test at that point. So it doesn't make sense to include that in the model either. The factors I ended up selecting are easily obtained, relevant, and predictive. Although sometimes we didn't see the predictive power that we wanted to. And in those cases, it sometimes helps to use feature engineering. So if we look at this importance plot, we can see that waist size over here on the left had it made up 10% of the decision-making power of our model. And there was some deviation there, which is seen with this black bar. But if you look at the right side of the model, we have a lot of these features that actually have very large deviations and go below 0 in some cases. It turns out that these are all related to physical activity. And physical activity from our research, we can tell is actually really related to cholesterol. So it's kind of confusing that it doesn't show that, but we might be able to engineer a feature that changes that. So by isolating these features, weighting them according to their actual impact on health and combining them into a fitness score, we see that the model can actually more clearly see the relationship between fitness and cholesterol. In the final model, I had 3 engineered features, and I was able to get a recall of 66%. Those engineered features were fitness, missing teeth, and the age at which they had their highest weight. Recall just means that it's capturing 66% of all the people that actually had high cholesterol. And that might seem like a bad test score, but it's pretty useful in a doctor's office. So the sample population had 17.8% prevalence of high cholesterol, and the model was able to capture a majority of those. But this does not replace the need for a blood test or a doctor. It's more a tool that doctors can use. When you're in your first visit, especially with the doctor, you might have all kinds of concerns. You might be sick, you might have your shoulder hurting, you might have sleep apnea, whatever it is. It can distract a doctor from capturing every single part of your health that they'd like to check. And that can have a big financial risk because if you develop heart disease, it's gonna be very expensive. Annually, we're spending $131 billion as a country on hypertension, and that issue's been growing for quite some time. If I were to run 10,000 people through my model and test the predictions, it would cost $54,000. However, the potential yearly savings from preventing the accurate predictions from developing hypertension would be $3.4 million. There's a lot of opportunities to expand this model. I'd like to add a lot more blood markers so we get a better picture of health. I think using a neural network might produce better results. I'd love to see it implemented if I can ever get it working where it's effective enough for that. This is the stack I used to complete this. Does anyone have any questions?